Thanks for coming. Sorry we're not as organized as we would like to be with the weather outside and the fog. We got a little bit behind. But we appreciate all of you coming today, giving us an opportunity to introduce ourselves, show you the products that we're going to be working with. Okay? And I just want to start by saying that over the last 12 months, I visited 25 countries. I've met hundreds of physicians, medical distributors, administrative people at hospitals, and not once have I seen anybody who has seen anything like we're going to offer you today. Okay? So we feel very excited about what we have. We're going to spend some time a little bit later today. But for right now, what I'd like to do is I'd like to give the floor to my friend and our partner here in Dubai, Sheikh Sultan. Okay?
Good morning. We'd like to welcome you to this small conference. I have disappointment, now you can hear me. My name is Sheikh Sultan, I'm Chairman of Gulf Holdings. As you know, since you live here, that Dubai always has this inviting environment for conferencing and adding more innovations, new things, products. We have the best of the best today, and on both sides we have the best in the field, we have the best doctors in town. What else do we need? Now, there is one exciting thing about today, and that's the fact that out of everybody in the room, I'm the only one who knows nothing about this. So we welcome you and have a great day, and I leave you in the hands of Dr. Snasky. Thank you.
Thank you very much for your coming, and I appreciate very much your attendance. And we are here in order to show the news in our biological features in orthopedic fields. But before the warm-up, we would like to introduce myself in order to know who I am. I'm born as an orthopedic surgeon as well as a plastic surgeon. I live and I work in Bologna, where I'm in charge of the department of implant arthroplasty, joint implant arthroplasty, in which I perform personally about 1,200 procedures, implant procedures, more for hip and neck. The ratio is about 95%. And I'm in charge of 3 units of regenerative medicine in Milan, Madonnina, as well as in Republic of San Marino, as well as in Bologna Health Center, that is Villa Hospital. My role here is to try to explain the main feature and the main possibility that this kind of orthopedic procedure can give, with the possibility to verify the very, very important outcome we get with this kind of tools and this kind of procedure. Well, we move very, very friendly, and unfortunately, the warm-up should be a bit boring due to the fact that the first speech is a speech that should be an introduction, a form of refreshment of our knowledge in biology and art biology. Well, we go first and we go fast in order to spare time. Stem cells is a cells. You see? Yeah. And also the line. It continues to divide and differentiate into various kind of cells. Stem cells, which are undifferentiated master cells that do not yet have a specific function, but under some stimulation, they self-renew and differentiate. Self-renewal needs to maintain the stem cells full through the life, and differentiation means that it should be important because specialized cells are used up and are used to replace dead or damaged cells through the life. One cell gives several lineage. Okay. We start with the science of stem cells. Stem cells are found at all stages of development, from embryonic stem cells that differentiate in all specialized cells found in the human body, and to adult stem cells that are capable of regenerating their tissue origin. Look at the three main kinds of stem cells: totipotent, pluripotent, multipotent. Totipotent are found only in an early stage of embryos and are the cells that can develop into a new individual, a complete organism. Pluripotent exist in an undifferentiated inner cell mass of the blastocyst and are the cells that can form over than 200 cell types that are found in the body. But the most important for us are multipotent stem cells that are derived from fetal tissue, cord blood, as well as adult stem cells, and differentiated, but forming a number of particular other tissues. This is an overview of early development we go over, but the most important thing is where are stems found. Embryonic stem cells found in blastocyst, in a very early embryo with 50 to 100 cells, and the tissue stem cells are found in fetus, baby, and throughout the life. Just some notice about embryonic stem cells. Embryonic stem cells are found, as we have stated before, at the blastocyst stage 4 to 5 days after the union of the sperm and egg, before the embryo implants in the uterus. There are, in the blastocyst, are about 100 cells, and it is not yet implanted in the womb. It's made up of the outer layers of cells, a fluid space in the group of cells called inner cell mass. But the most important thing is that embryonic stem cells should be taken or could be taken from the inner cell mass and should be put in culture in the lab in order to grow more cells. Embryonic stem cells are exciting because they can make all the different types of the cell in the body. But the big challenge for scientists, for us, is to learn how to control these fascinating cells. If we could force embryonic stem cells to make whatever kind of cell we want, then we would have a powerful tool for developing treatment for varied forms of disease. For instance, we could grow new insulin-producing cells to transplant into a patient with diabetes. But it's a very great deal to learn before such therapy can be developed. So, undifferentiated human embryonic stem cells can rise and can give you the possibility to treat spinal cord injury, as well as heart failure, as well as diabetes, or as immunotherapy, or for the use of bronchitis, osteoarthritis as well. But let's go to the important stem cells that for us are fundamentally in orthopedics fields. There are stem cells in our body at the time, and they are essential for keeping us fit and healthy. And they replace the cells that are damaged or is down. Tissue stem cells can only make the kinds of cells found in the tissue they belong to, so that blood stem cells differentiate only specialized types of blood cells, like red blood cells, white blood cells, as well as platelets. And this is multipotent. But let me show a particular type of stem cells that are called or named induced pluripotent stem cells, because this stem cells is very, very important. In 2007, a researcher go forward in research with human to transform human cells for human cells too. And they use stem cells that are made in the lab are called this induced pluripotent stem cells. But just like embryonic stem cells, they can make all the different types of cells in the body. So we are named pluripotent. But what's important of this IPS cells? Scientific have particular genes to cells to add genes to cells from the body to make them behave like embryonic stem cells. In other words, we are speaking about a genetic reprogramming. Genes give cells instruction about how to behave. So this process is a bit like changing the instruction in a computer program to make the computer do a new task. Why they are so excited? Use of IPS cells is fundamentally to help to treat disease like Parkinson's or Alzheimer's. And we make IPS cells, and we use the cells to grow the specialized cells that the patient needs to recover from the disease. The cells would be made from patient's own skin cells, so the body would not reject them. So, from a cell from the body, particularly skin cells, with the genetic reprogrammation that is add certain genes to the cell, we create a induced pluripotent cells that behave like an embryonic stem cells, so that can differentiate in all possible types of specialized cells. And the advantage is that we do not need for embryos. Go more. Tissue stem cells are neural stem cells, hematopoietic stem cells, good stem cells, or we go to the mesenchymal stem cells. There are the mesenchymal stem cells that are allowed and are able to differentiate only in three form lines: bone, cartilage, or fat. And differentiation is made by induction of some factors like insulin or dexamethasone or ascorbic acid, according to the kind of stimulation and the kind of cell you want to get. And now we go to stem cells used in orthopedics. Where the stem cells live? In bone marrow as well as in adipose tissue. Unfortunately, they are very rare. Theoretically, 1 in 10,000 marrow nucleate cells. that is 16 ml marrow spirate that yields only from 7 to 9,000 stem cells. But for therapeutic levels, we require about 10 at 7th or 10 at 8th thousand. For orthopedic application, two main types of mesenchymal stem cells have been used actually. Bone marrow derived that we harvest by a needle through a bone marrow aspirate, or adipose derived that we obtain via liposuction. The purpose of mesenchymal stem cells are fundamentally three: support hematopoiesis, to attract hematopoietic stem cells, that is named homing, or immunosuppression. We go fast because this is a theory, but to support hematopoiesis, they do by cell-to-cell interaction of growth factors production. And for homing, that is recruitment of circulant hematopoietic stem cells in the bone marrow, that should be that occur by cell-to-cell interaction as well as by growth factor production. Immunosuppression is very, very important. Mesenchymal stem cells have an important role in TB and T lymphocyte as well as dendritic cell maturation. They stop mitotic division, they modify cytokine secretion, and immunosuppressive effect on the mesenchymal stem cell of T lymphocytes and B occur through cell-to-cell interaction as well as by growth factor. But about the advantages of mesenchymal stem cells, we are sure that they are autologous, so that we have no major ethical issues like we have with embryonic stem cells usually. But mesenchymal stem cells can be expanded in vitro, and this is a limited supply of therapeutic cells for our needs. Furthermore, they do not express AAE2 antigens, so allotransplantation is possible too. And there is a strong evidence that in vitro and in vivo they could have a complete differentiation. If you look at the clinical therapy based on mesenchymal stem cells, we have three fundamental fields. Cytokines, pump, and growth factors are very, very useful, as well as cell therapy of substitution. But the most important thing for this use of mesenchymal stem cells is the tissue engineering strategy. That is the fields for which we are all working in the big fields for present as well as for the future time. Cell therapy of substitution is like osteogenesis imperfecta therapy, and cytokinase constant growth factors mean that mesenchymal stem cells are able to secrete molecules that are able to stimulate angiogenesis, decreasing fibrotic tissue and scarring. That is very, very important because this effect are fundamental in oat stroke as well as cerebral ischemia treatment. But let me go to the most important fields for orthopedics. Tissue and gene strategy. For instance, we have a lot of possibility to explain this in the next speech. Mesenchymal stem cells should be loaded or could be loaded in a specific scaffold that is able to give us, in this case, osteogenic stimulation and a most favorable environment of that differentiation in osteoblasts. But now there are some notices that are fundamental to explain, to underline. This note should be repetitive in all speech, but are fundamental. Mesenchymal stem cell differentiation in a specific track may be achieved as a result of environment, mechanical stimulation, and growth factor that are present in the platelet gel and are able to stimulate cells toward osteogenesis or chondrogenesis. But the potential of the multipotent cell may be considered not only as intrinsic capability of the cell alone, but also important interaction between a cell with its physiological niche that provide the schematic world. A niche what is the niche? Is a microenvironment around stem cells that provide support and signal that regulate self-renewal as well as differentiation of the stem cells by the direct factor, the direct contact by soluble factors or intermediate cells. And this suggests that no cell selection and expansion in laboratory might be required, as well as happen with autologous chondrocyte transplantation. And consequently, the transplant can be performed in one operative procedure. In order to have a tissue regeneration tissue, we need what is named as Trinity healing: stem cells and appropriate extracellular matrix of support and growth factors and other soluble proteins. Inside the bone marrow, there are different cellular populations with regenerative capability, and the lesion cell-to-cell which take place regulate its activity and exploit an regenerative potential by production of growth factors and other soluble proteins. And in this figure, you can verify the cell trinity in which adjuvant cells, scaffold, and growth factor interact together in order to create the healing cascade that is the process that help and give rise to the healing of a wound, the healing of every injury. And this find support the choice of using the whole subset of medullary cells and to transfer the whole regenerative potential to the lesion site. Moreover, we have to consider some other problems. By the use of stem cells without resorting to a cell expansion, we have no risk of cancer genetic aberration that should be had in the expansion step. Barmac is an operative procedure of only 15 to 20 minutes. The cellular expansion needs time, equipment, and appropriate setting instead of. And expansion implies also the transfer of the withdrawn and expanded cells with all problems that are linked to biological safety and traceability of the product which grow out. So, we have two possibility solutions. When you use concentrated bone marrow in orthopedic and regenerative medicine, we can resort to treatment of minor defect or unifocal coin huge defect if you want, with one step by using mesenchymal stem cells directly in operative room in one surgical step, and by marrow aspiration by iliac interest sample as well as by tibia. Is a therapeutic procedure that is considered minimally manipulated, autologous, and homofunctional. And important example is made by resorting to the tools of Biological Therapies company. It should be done on bone level as isolated or associated to BTM fossilized bone or DBM or other kind of bone substitute for the treatment of non-union, as well as aseptic necrosis, or at the level of cartilaginous osteochondral fields when it will be loaded on a biocompatible support, an example, a yellow fast, acting as a three-dimensional scaffold for the treatment of post-traumatic or degenerative cartilaginous and osteochondral tissue defect. The second possibility is to resort to IDSC. That should be theoretically important in the treatment of major defect and osteoarthritis, but all kind of procedures works well, and the resort to ADSC is important in different situations and in different cases, for which I explain in the next speech. At the present, a lot of studies have been performed to test the possibility of using ADSC to reconstruct damaged cartilage tissue for treatment of condyle knee lesion and to limit arthrosis. And FDA approved about 12 clinical trials when administering ADSC for orthopedic regeneration. But actually, the approval is only linked to injection and not to the diet manipulation of adipose SC for the treatment of severe osteoarthritis. So that if you look at this schema, you can verify that the current FDA regulatory status are at the level of bone marrow, the level of adipose fatty tissue. We have the bone marrow nuclear cell isolation with its concentration, in which tissue doesn't need FDA approval. But when you perform a bone marrow mesenchymal stem cell culture, you need FDA approval. As well as the case of resorting to adipose fatty tissue. You can use a simple adipose graft, which procedure consists of concentration, selection, and concentration, and tissue doesn't need FDA approval, but approval is needed when you resort to stromal vascular fraction as well as to adipose mesenchymal stem cell culture. Let's go to the surgical technique. There are two different experiences. I started 7 years ago with a different solution, and the main competitor were Harvest, IOG1, and Bio. For this need, the first step is platelet jet production. 120 milliliters of patient venous blood is harvested and processed in order to provide 6 milliliters of PRP, that is platelet-rich plasma. Platelet-rich plasma is fundamental because it's considered it's the activator of mesenchymal stem cells, so that you use this blood, this concentration, this PRP, because of the possibility of gain a lot of growth factors, and the concentration, the centrifugation of the peripheral blood give us the possibility to increase up to 600 times the content of growth factors in order to activate at the best the mesenchymal stem cells to transform in the lineage we want to have, for instance, bone or cartilage. The second step is the aspiration of bone marrow. A total of 6 milliliters of bone marrow is created, is harvested from the anterior or posterior iliac crest. I prefer generally anterior iliac crest due to the fact that patient is a supine position and instead of prone. And the procedures is able to eliminate red cells, and the final product contains hemopoietic stem cells, mesenchymal stem cells, as well as vascular progenitor, immunitary cells, and platelet and growth factors in a final volume from 10 to 20 milliliter. The first step is the concentration. The harvested bone marrow is processed directly in an operative room, and this is fundamental because you cannot move your sample from other side. And the final product of about 6 milliliter is a concentrate containing a nuclear cell that we have just obtained within 15 minutes, 15 to 20 minutes of nuclear centrifugation cycles. And the quality of the final product is high, with clinical efficacy for 7 days and reproducible. But nowadays, what is our experience? Our experience move to a new solution that has been expressed by Biological Therapies company with Biomac. Bone marrow aspiration catheter is a tool that is a simple tool, but it's very, very important because first of all, we have available different length of the needle, of the catheter. Generally, for our needs, 45 as well as 60 millimeter length are more useful. And the Biomac catheter contains 8 large, smooth bevel edge fenestration, which allow for gentle bone marrow aspiration. But the Biomac incorporates a plunger component that inserted down the catheter creates a void where bone marrow pools. And we draw a greater draw area resulting in a higher aspiration efficiency and an easier draw when compared to different other competitor devices. The Biomac can be inserted with any standard surgical drills. And this should be important because this delivery system eliminates the potential of microfracturing as well as bruising and subsequent pain from hammering. You can look at the catheter assembly with the catheter and the trocar and the plunger. And the step that you need in order to get the need mesenchymal stem cells is a centrifugal and automated blood cell separator named BioSpin that has the advantage to present higher volume capacity and with consistent reproducibility of the concentration. Give me the possibility to show in a more deeply the main step of the procedure. This procedure is very, very simple. You have a package in which you have the needle and plugger. The catheter is which insert the trocar and the plugger. At the same, we have a dual adapter. Catheter is washed into anticoagulant solution. After that, we put associate a drill adapter into your drill, and the step is to try to look for the center of the anterior iliac spine. And at this level, when you use your finger, your thumb and your index, you just create the salience where you can drill without any problem, and you can put inside the catheter. The catheter is pushed up to the level of the skin or less according to your needs, and after this procedure you disengage the drill, you remove completely the trocar, and you substitute the trocar with plunger. After that you can adapt completely, and you can arrange and you can screw your sling to the tools in order to get a very, very important fluid that can help in a very, very fast fission. Finally, you get your amount, that is about 60 milliliters of blood coming from the bone marrow, that should be concentrated in this centrifuge in order to obtain 6 to 6.5 times of concentration, increasing above the baseline. Another possibility is to try to resort to different sites. When you have to manage at the level of the knee as well as the level of the ankle, or the level, not in this case at the level of the hip, should be suitable and easier to resort to different approach. And different approach is made by proximal tibia bone marrow draw. The technique is the same. The technique is just like the previous step, but in this case we have to manage at the level of the knee. So the first step is to try to palpate laterally and medially the tibial tuberosity, anterior tibial tuberosity, looking for the spaces that lies just below 2 fingers from the joint line. And at this level, just over the insertion of gracile semitendinosus of the hamstrings, you can find the portal, the approach, in order to drill at the best your catheter. The orientation is important too. Theoretically, you can use orthogonality positioning as well as light obliquity, according to the side from which, deepening the needle, you can find the amount of the blood that can flow very, very profusely. You remove the drill adapter after drilling, and you perform the same step: catheter removal, prime insertion, and after plunger removal, you screw your sling in order to get off all blood that we need. After centrifugation, we resort to this fundamental step of reconstruction. In bone repair, a DBM or hydroxyapatites as well as bone graft autologous or hydroxy scaffold is used for cell support. The scaffold is loaded with 2 to 6 millimeters of bone marrow concentrated in order to position in the delivery device. And in these cases, after this approach being generally performed with the patient in supine position, we identify bone lesion, and after debridement, accurate debridement, we refill the large bone defect with bone graft or substitute that is previously loaded by mesenchymal stem cell by a bone marrow concentrate. After that, it's fundamentally to activate mesenchymal stem cells to transform themselves in the special and essential lineage that should be used, in this case, bone, so that we activate with bone fracture, with growth factor that we have just used the first step by growing, by taking by peripheral blood in order to get the fundamental result that is usually made as Trinity-like process. The same procedure apply for cartilage repair. In these cases, you, after the bone marrow harvesting phases, a standard knee vastus approach has been performed, is performed. Patient should be supine, and after identify the kissing lesion, we perform debridement, resulting in a zone for which we have the hedge, that are net hedge, with the surrounding cartilage that act as a shoulder, and you put your scaffold inside the defect in order to replace according to the shape you have just done, and after that you put the scaffold that has previously completely embedded in the concentrate, bone marrow concentrate, in order to restore completely the defect, and in order to have a complete covering of the fracture. After that, the final step is the activation of the mesenchymal stem cells in a lineage of cartilage, and the activation has been made by growth factor that we have just used, we have just got by venous sampling, concentrated venous sampling, and activated orienting to the spatial and fundamental cartilage lineage. The possible treatment is common, either for bone, either for cartilage, according to the depth, according to the size, according to the site of the defect. There are some modifications. Theoretically, one day after surgery, we start with the kinetic, with the gradual passive mobilization of the knee or of the ankle, and 4 weeks post-op, patient has advanced muscular reinforces exercise, and 6 weeks after surgery, we get complete weight bearing. But this situation are completely different according to the size of the defect, and according to the shape of the defect, and according to the site of the defect. Because in case of femoral patellar joint, patients weight bear the day after discharge, the day after surgical procedure, and in case of weight-bearing sites like femoral condyle or tibial plate, weight-bearing is not allowed for 4 to 6 weeks from surgical procedure. I thank you for this first speech. I know that it has been noisy, but and it is it's quite buried, but it was fundamental in order to refresh some knowledge, some notice about stem cells, and to introduce to the fields that we are acting. Now I would like to, because before to start the discussion, I would like to go forward to the second part of this theoretical presentation, and is the part in which we are speaking about the use of PRP, that is quite interesting and is very, very important in order to try to treat patient not only in by surgical procedure, but only with injection. And meanwhile, is someone that would like to reply, or would like to put some question, or we perform discuss after? Okay. I know that it's boring, but we go faster because the most important part is the part that is linked to the clinical application in very, very important cases, and surgical procedure as quite into it. What is PRP? PRP is a simple whole blood that is centrifugated to create an increased concentration of platelets that should be with or without leukocytes. What is so special about platelets? Well, we know that platelets contain granules that store growth factors. Alpha granules, for instance, are released when platelets aggregate and adhere site with injury or inflammation. Is activation of platelets and the release of the various growth factors that they make that is the key to enhance tissue repair and to give healing. What do these growth factors do? Chemotaxis, cell proliferation, and possible they can have a systemic effect, but the primary growth factor's role is in soft tissue healing and repair, and occur by PDGF as well as TGF-β. Their effect on tissues should be immediate or early or late, and is related to inflammatory response, chemotaxis, and fibroblast mitosis. That are all the steps that are fundamental in the realization of the healing process. And all these factors are important in wound repair. So it appears that through a complex series of chemical and cellular events, growth factors cause a rapid and sustained increase in number of fibroblasts in the area to cause stem cells maturation. A colleague of ours, Mr. Arnold C., just in 2009 said that while the clinical benefit of PRP in enhancing the healing of musculoskeletal tissue are only beginning to be explored, compelling rationale for use of PRP is the treatment and repair of various connective tissue structures. But PRP, look at this slide, PRP is not stem cells. PRP is not mesenchymal stem cells. PRP is not a disposition. PRP is not bone marrow. And what about the current clinical use of PRP? For a lot of people, everything and anything. it should be considered a snake offering today. It cures rheumatism, it grows hair, gets rid of wrinkles. No. Current clinical use of therapy are limited. And comparison rationale is to try to treat tendinitis as well as first. About meniscus repair, ligament surgery and tendon repair, there are some works, some papers that are speaking about the outcome, but there is no complete agreement about the outcome. So that's why the interest in PRP. Historically, there has been interest for a long time at the research level, and the clinical interest started with the hypothesis by Mishra. Could the treatment of common clinical disorders like lateral epicondylitis be improved by injection of PRP in the tendon? Yeah. Look at the clinical model. All of us know that epicondylitis or tennis elbow is a common disorder. 5 out of 1,000 patients for a year has got this kind of situation or disease. The natural history is highly variable with a lack of uniform response to treatment. And this is the case, lack of uniform response to treatment. Typically, it's seen over age of 35, and the most important causes is micro-iterative traumatism. Historically speaking, there is a loss of the longitudinal alignment of collagen fibers, hypercellular with no vascularization, no acute inflammatory cells, and angiofibroblastic hyperplasia. But look at this. What about the disappointing effects of current treatment by corticosteroid injection? Corticosteroid injection interrupts the inflammatory cycle, decreases proteoglycan symptoms, weakens tendon tissue, can induce atrophy of subcutaneous fat, and can cause skin discoloration. Generally, should be intolerance of many oral meds as well as of corticosteroid. So that the clinical application of PRP in the treatment of tendinopathy according to Mishra is a treatment when difficult patient mixed with some healing fat surgery or multiple cortisone injection. But we spread to this indication, and actually after a complete approval process by FDA, the PRP injection, it should be considered the first choice in the treatment of chronic epicondylitis, as well as acute or subacute of epicondylitis after first line of treatment that is used by NSAID as well as physiotherapy care, that they didn't have the possibility to get healing. So that we start with office injection of PRP, and this is the protocol. We draw 3 cc of peripheral blood, we place blood in GPS canister, and we centrifuge for 15 minutes. After that, we remove platelet to plasma. I will show big result for 30 seconds. And we inject 2 to 3 cc of PRP into external carpio radialis brevis. That is the peppering technique. Post-injection management, rest, non-safe, no stretching program, no high loading activities until criteria met known. Office injection, the outcome for 35 cases. Pre-treatment average VISA score 31.4, and we can verify that at 3 months treatment score passed from 67.5 to 75.2 at 6 months, and we got a quite good result at 2 years follow-up with the score that is quite an overlapping of the first score. So that PRP has emerged as a valuable biological treatment for chronic tendinitis. You can use as a protocol, for instance, in patellar tendinitis, and you generally use multiple injection by confirming the location and the perfect location by ultrasound guide. Our protocol showed that in the first 4 cases, VISA score passed from 39 to 70.2 at 2 years follow-up. And the VISP PRP convenience kit should be actually our choice after certification with VISP Magellan system. The Biospin Magellan platelet separator is very important because it customizes the PRP product. 6 mm of blood processed to 6 mm delivers a platelet concentration that's 7 times baselines. The most important growth factors that are fundamental in tissue healing are TGF-B as well as FGF and EGF.